Buck, you look good.
Okay, great.
Thank you.
We're recording.
We're recording. But Joffrey, welcome to the Vagina Doctor podcast again.
Thank you.
Yeah, he's our first repeat guest.
Yeah.
Thank you. Appreciate it.
And it's almost 2 years, actually.
Is that right?
Yeah. Time passes.
Wow.
And we were looking forward to having you come back again because
Great.
we've learned a lot in the interim. And I'm sure you've got a lot to tell us about what you've been doing.
Yeah.
So welcome. It'll be fun, I think.
Yeah.
You have a new podcast.
Or you changed his podcast.
Well, I have
Changed
two-
it up a little bit.
You have,
2 longevity podcasts.
okay.
One of them, so I realized that one of the challenges is that I'm pretty academic on this stuff too.
Yeah.
And that doesn't appeal to everybody.
Right.
But there is a subsect of people who really want to dive deep.
Absolutely.
And so that one I veered off and called Longevity Roadmap.
Okay.
And that one it's really fascinating because I'm now really getting pretty much every major scientist that I want in the world right now.
Wow.
And that's Dennis Hughes is the one that told us we needed to circle back to you because of this podcast.
Yeah. Now, the other one is more morphed into the world where I think most people prefer to be, which is I want to learn this stuff, but I don't want to go home and read in order to understand what you're saying. And so that one is called Longevity Junkie. And that one is a podcast with me and a co-host. And the co-host is Nikki Lee, who's an actress and a model. And she keeps me honest.
That's good.
She keeps it down to earth because she's very interested in this stuff. But of course, she didn't go to medical school. And she'll quickly chime in when things are getting wonky.
Yeah.
And she'll also, and it's just, I should say that show is a lot. It's an entertainment show as much as it is. You learn, it's a kind of show where you listen to it, you'll learn stuff, but you don't really realize you learned it because you were laughing a lot of the time
Great.
because we have these segments in there and Nikki's entertaining and
Yeah.
she brings out a different side of me as well.
I've listened. So
Yeah.
good. Yeah.
And have you met Dennis Hughes?
I have.
Okay, great.
Yeah, Dennis was on the old, I think we were, I don't remember, it was Sapio back then, but yeah, I had him
Okay.
on. Yeah.
Great. Yeah, he's been a great addition to the community.
Mhm,
I
sure.
spend a lot of time talking to him and we share patience. and
That's
so
great.
on. And so
Yeah.
he's a bright guy.
Yeah.
That's really fun. So let's go, because I'm sure I can't be as entertaining as Nikki.
Sure.
I'm
I
sure
bet
you
you can.
agreed.
She might be better looking than you.
Yeah, just a touch. I really want to look at any of what you think of milestones, big changes that we knew about, maybe thought about a couple of years ago, that now are either we've seen that they're nonsense or we've seen they're really useful and helpful
Yeah.
for people.
Yeah. And I'm glad you asked that because part of this journey is, there's this effect, I think it's the Dunning-Kruger effect or something, where you start out in something and you understand that you don't know very much. And then you start to learn, and before you know it, you feel like you're an expert. And then you continue to learn, and then you realize
you know
you don't
nothing.
know anything.
Yes.
And so I've circled back to feeling confident about what I was saying and certain things to now feeling, gosh, I'm not so sure about that one anymore.
Yeah.
And I think so what I'm trying to do is like when I present this stuff is to present the science, and the science, especially in a show like Longevity Roadmap, where we have a lot of people who are supposed to be the expert. You find that they have diametrically opposed views on some of the most important questions that we deal with on a day-to-day living just for people. That's where I'm at. But I'm happy to tell you about some of those things, certainly.
Yeah.
Absolutely.
Let's do it.
Let's start. I think we talked about the different types of things. You break down the categories of things that we think are important, that I think are important, you think are important for longevity. And you start with diet. Okay. So diet, I think pretty much everybody agrees now that low simple sugars, right? Try to keep euglycemic. In other words, keep your blood sugar as nice and flat as possible. Your hemoglobin A1C should be nice and low. That everybody pretty much agrees on. Okay. Now here's the two other things that I talked about before that I'm not so sure about anymore. One is the issue of fasting has become far more complicated than I thought.
Okay.
And I'm sure you know what I'm referring to at this point. The thing is that fasting is such a broad term. It's like calling somebody a millionaire right now, right? You're like $1,000,001 or you're a billion. You know what I mean?
Yeah.
So fasting is a very broad term. And what does it mean? And I think that what I had thought and what I think a lot of people were thinking about time restricted feeding. So for example, the 8 hour or less per day thing, a lot of people thought that was what fasting was and that those are where the benefits came from. So I've had a chance to talk to some really smart people on this. And there's a couple of issues. First of all, the real benefit of that fasting doesn't really occur until you are not eating for about 3 days.
Wow.
Right.
Oh my God.
Because we usually think about the benefits of fasting when we think of cellular senescence or autophagy of cellular senescence. So basically you've got these zombie cells that a lot of times as we get older, cells instead of just dying off because they're old and making room for new ones, they'll just stick around and be zombies and start secreting these inflammatory chemicals, and it creates a big problem. That's part of one of the things that we think that causes aging biologically. But the effects of fasting really only help that after about 72 hours of fasting.
Wow.
So the real benefits of fasting as we think about them are not these 8 hour windows or less. Now, there is, I think, a value in having a circadian rhythm to eating and not eating. The guy I learned the most from on this, and I think that gave me a different perspective, is a guy by the name of Walter Longo down at USC, and he's done a tremendous amount of work on this. And his take is, okay, there was this study that came out, I think, a year ago. It wasn't actually a study; it was a paper that was presented at the American Academy of Cardiology, that basically suggested that people who were actually doing 8 hour windows or less had a higher risk of cardiovascular death.
Great.
So I brought this up to when I was interviewing Walter Longo.
Is it just because it's the stress on the body?
It's not entirely clear.
Okay, go on.
Yeah.
Oh, I won't interrupt. I'll keep going.
So I brought this up with Walter Longo because I'm like, why, this doesn't really make sense. And he's the fasting guy and stuff like that. And when I brought it up, he was familiar with that abstract, which, by the way, everybody was like, just not enough data, poorly done, not peer reviewed. But Walter said, listen, there's multiple studies on quote unquote breakfast skippers. That's what we're really talking about
that's
here.
really, yeah.
Breakfast skippers that show higher levels of high blood pressure. They show hypertension, cardiovascular disease, the whole 9 yards. And he sent me the studies, and I'm like, good point.
Yeah.
Right now, again, he's the one who came up with this thing that he calls the fasting mimetic diet. This is something that's put out by a company called Prolon. That's PROLON. Basically, it's like a 5-day mimicking diet. So it fools the body into thinking it's actually doing a fast for 5 days. I'm happy to promote that for Walter because I know he doesn't make any money from it. He's now using it in cancer patients and a whole host of other diseases that we think that fasting is benefiting from. But Ned, here's the issue: is that I think sometimes when we think we're doing the right thing, we could be hurting ourselves, right? So I don't actually think that an 8 hour window is something you should necessarily be doing on a long-term basis. Now, a lot of people will say, here's some other data though. If you do that 8 hour window or less, you're actually metabolically getting a lot healthier. your fasting insulin is going down, you're getting better glycemic results and that kind of thing. So what do you do with that? So what I've thought about is I think those windows, those short windows are good interventions. I think of them as like being on a medication for a period of time to get your metabolic health in better order. But based on what the Volter's studies and everything I'm seeing, I don't think it's necessarily, and I'm not going to say one way or another because who knows, right?
Yeah, right.
But that's the issue is if you don't know one way or another, be safe about it.
Yeah.
And I would say that, that those shorter windows probably are not something I would do with the intention of it being a longevity promoting behavior.
But it can be a weight management.
It can be, but I think I would approach that as an intervention.
Yeah.
Like 3 months, 4 months, something to get down and then try to get into metabolic health. And then if you look at the data, it's not clear. So there is this data that suggests it could be bad for you. So if it's something could be bad for you, all right. So I asked Volter what's probably the safest, and he says probably a 10-hour window. 10-hour window, basically.
Yep.
And that's super easy for everybody, right?
Oh, yeah.
Super easy. But what it does do is it still maintains this sort of on-off with nutrition. Okay. So that's one thing.
Okay. Elaborating on that.
Yeah.
What's the mimetic diet?
Fasting mimetic diet is, Prolon sends you these diets that are pre-made. They're for like day 1 through day 5. And they're all about maybe 1,200 calories or something like that. But what Volter's done is he's essentially created these diets that nutritionally completely fool the body into thinking that it's not eating at all. And so he's got plenty of studies showing that, again, day 3, that's when that autophagy, getting rid of those senescent zombie cells and all that stuff is happening. A lot of people are using it with diabetics, really useful diet. Although, frankly, I didn't find it that easy to do.
Oh, did you do it?
I did it. But
Just to try it.
I tend to eat a lot. I'm like 220 pounds. I'm 6'4". So but for me, like it was hard. But I've heard other people say they didn't think it was very hard at all to do. So
I know he's going to order this right after you. I don't want you to do this. I'm going to say no.
I think I've had multiple people try it, and it seems to help some odd things. Like I had a friend who was dealing with some long COVID issues for many years. I saw some data on fasting and long COVID, and you could try this.
Yeah.
It seemed to benefit this person. Yeah.
But those are diets that are prepared.
Yes. It's very
Right.
easy.
Okay.
Yeah, it's very easy.
Interesting.
Yeah. Yeah, I'm sorry.
That's a good one. I don't know.
There he
Thanks
goes.
a lot. Here we go.
Yeah.
That's right.
Yeah.
Yeah.
Because he is the faster.
Yeah.
So, yeah.
Me too. I did the windows for 4 or 5 years.
Yeah.
For me, part of it is like I'm naturally a window guy. I don't like eating breakfast. I don't,
Yeah.
that kind of thing. But data's data, and
Yeah.
Yeah.
hard to completely throw out. Should listen to my Volter Longo interview, actually.
Mhm.
Yeah.
I think
Yeah.
that's what needs to be done.
Okay.
Yeah.
Give
I'll do
us
that
another.
first.
Give us.
Another
thing.
twirl.
Okay. So Volter's really screwed with my mind on this stuff.
I love that though.
This is, okay, so we talked about protein, 0.8 to 1 gram per kilogram. Now, here's the thing, is that this is the thing that drives me crazy. Like you have guys like Peter Attia and plenty of others on the side of that heavy protein side. But again, you go to like Volter and he's showing you like demographic data, population data. And then you look at a guy like, what's his name? I can't remember. I recently had him on my show. Anyway, never mind. He's another advocate for lower protein diets and stuff like that. Specifically, just basically saying that until you're in your late 60s, you really shouldn't be hitting the protein that hard. And that the data suggests that you're actually counterproductive to longevity. Now, again,
And if you're beyond that, and if you're beyond that in age,
then you should hit the protein
Yeah.
harder. And the reason is because at that point there's this. So the concern for the low protein guys that I've talked to is the higher incidence of cancer. But once you get past a certain age, that risk factor seems to go down compared to the risk of sarcopenia, which is muscle wasting and basically wasting in general. And so that's when even a guy like Volter will say, we should be pushing that protein higher at that point.
At what age?
I think I want to say it's mid 60s or
Okay.
late 60s. But yeah, there's pretty clear on the data there, what he was showing as well. But again, listen, there's plenty of data. Here's the other problem, as you probably know, if you look at the biggest indicators of longevity, it's basically lean muscle mass and VO2 max, right?
Yeah.
I think
those are still believable.
Yeah, no one argues that point, but the issue is the path there.
Yeah.
So when you have a situation where you have smart people. Dean Ornish was the other one I was going to tell you about. So have you heard of Dean Ornish?
Yeah.
Yeah.
So Dean is a very anti-heavy protein. I interviewed him on Longevity Junkie. Dean Ornish, the Ornish protocol, reversing Alzheimer's in patients with his diet. It's pretty incredible what he's doing. A UCSF guy, so I throw that out. But he and Volter on one side, you got like Peter Attia and some of the other really smart people on the other side, and they're basically have completely, utterly different opinions. So what do I tell people? I just say, do what you think you want to do here, because I don't think in a situation where you have like really smart people showing you data that is diametrically opposed, probably stick somewhere in the middle is my thought. I don't know. I always feel like instinctively really driving enormous amounts of protein does not feel good for me personally. I've done that. And for me, that's like the equivalent of 220, 230 pounds. It's eating a couple of ribeyes a day just to it doesn't feel right. Yeah. But I'm not saying it isn't. I'm just saying, so I think sometimes when the data's not clear, I think you got to trust how your body's feeling too, a little bit. Another confusing thing.
What about metformin?
Yeah, listen, I think that the issue with metformin is that it's not, Neil Barzilai is doing that big study, and we'll probably have some data about that. But I and other people I've talked to who are hyper-focused in this area, like Matt Kaberlein, for example, is another really smart guy. I tend to believe it has more to do with the euglycemic effects. The fact that it's a diabetes medication.
Yeah.
If you look at the rodent trials, metformin is not one of the medications that creates extension in living. There's other medications that we know that rapamycin clearly across the board seems to do something there.
Yeah.
And there's actually another diabetic medication that in the trial that I'm talking about that actually was positive, but not metformin. So
it comes and goes in terms of belief in. It seems, some people say it's great and this is what you should be doing, and other people say, no, it's not. Really, just as you're describing, I
think it's the blood sugar. I really do. There is some question if the metformin actually activates this AMP kinase pathway and the sirtuins and stuff like that. It's possible. But the major study on that people always talk about essentially was not reproducible when it was controlled better.
As you mentioned rapamycin, what's the general feeling now about it?
Rapamycin seems to be one that there's not a lot of naysayers on.
Okay.
Yeah.
Everyone says it's good.
Yeah.
And who's come up with this once a week idea, or
what's the rationale?
What's the rationale? But that and the dosage. And
I don't know who it was. I know there was a physician who passed away recently who before people were looking at this, writing about rapamycin and how it had helped his. I think he had some issues with heart failure that he had worked himself out of. Wow. With some of the anti-inflammatory effects of this. But okay, across the board, people generally think that this is a medication that is helpful, at least in the longevity community. The reason for the pulsatile nature of it, again, this is a longevity roadmap thing, by the way. Okay. This is the more nerdy like stuff. There's two complexes to the receptor, the mTOR. So there's TORC1 and TORC2. TORC1 is the one that we want the rapamycin to hit, but if the rapamycin gets in higher levels as it starts hitting TORC2, TORC2 is the one that gives us a lot of side effects.
Okay.
And so that's the reason. A lot of the side effects and that kind of thing. So the idea is if you pulse it, meaning taking it once a week or so, that you're only going to activate, or you're only going to hit the TORC1 receptor.
Okay.
And in the longevity space, again, this is hand wavy stuff, right? But a lot of physicians are doing it, including myself, is somewhere between 6 and 10 milligrams per week at one time.
Yep.
And so side effects, usually some people get these aphthous ulcers.
Right.
They just go away. They're generally ulcers in your mouth. And if you get that, you back off on the dose. So.
Are you still taking it?
You talking to me now?
Yeah.
You're talking to me? Yeah.
Okay. I thought.
Again, 6 milligrams once a week.
Yeah, 6.
Yeah.
6.
No, I think every animal study that's done is positive.
Yeah, cross
So,
species.
yeah.
Cross species.
Yeah.
Yeah, it's pretty amazing. And that's really, and by the way, that is really the only drug that's true about.
Yeah, absolutely.
Yeah, I mean, you can talk about metformin or any number of drugs that people are taking. Rapamycin is the only one that is.
Something that's come across my horizon recently on my radar is Tadalafil.
Yep.
And I've felt all along that ED was like the canary in a coal mine.
Yeah.
This is that if once ED is just starting, when there's any hint of that at all, it may be an indication of generalized cardiovascular disease. Yeah. And so I've just come across a few people recently, and there was just a study that Dennis actually sent me that showed significant difference in people that were taking Tadalafil. Not for ED, just generally, we're taking it.
Wait, did just men take it? Or is it?
Is
this a men's study?
This is a men's study,
okay.
Yeah.
I don't know what it is.
Erectile dysfunction drug, but there's in the 5 milligram per day dose is like a daily dose. Yeah. That's what he's referring to.
Okay, got it.
And that was actually one of the questions. Is that the dose that's thought to be? Because it makes sense to me. And it's this study showed very significant differences in cardiovascular disease and death from all causes being diminished.
So I had a podcast, and it's about a year old now, literally called Erectile Dysfunction, the canary in your coal mine.
Oh my God. That's so weird.
We addressed this with a urologist about a year ago, and I started taking it too. But now I have another friend, Justin Howman, who's down in Cedars-Sinai, who's also talked about this very much, that it really is there's two things about it. First of all, we don't really know how much that, and I don't know the study that Dennis is showing, but I don't know how much of the effects of Tadalafil itself are helping with the cardiovascular stuff. However, we do know that it is the canary in the coal mine. If you've got ED issues, it makes sense, right? It's vascular issues, blood flow. Right. So then it is something that you have to get the rest of your body checked out about for sure.
Yes.
So that's one issue. The other issue is there is feed forward problem with erectile dysfunction. There's a use it or lose it type thing that, especially with nighttime erections, which healthy men get, that if you're not getting that kind of constant blood flow and stuff, the thought is that there may be some atrophy over a period of time. So there's a use it or lose it thing. And so my friend Justin down at Cedars suggests that pretty much any male patient at age 40 should be on it, whether they're having issues or not.
Yeah, that's what I've just, and this was just a theory of mine. I'm a gynecologist, but I do have male patients, and we have shockwave therapy available for treatment of ED. But overall, I thought exactly this, that this is maybe the first obvious sign of cardiovascular disease. It needs to be paying attention to, and that's when you need to look at things. And maybe it's a little earlier than a calcium score, which is pretty late. Yeah. Having calcified plaque in the coronary artery seems to be a late sign.
Yeah, sure. I think anything that gets people starting to think about checking on their heart early is a good thing. But
But did you seriously use that phrase?
Yes, specifically, the show was called "The Canary in Your Coal Mine."
Okay. Oh my God!
Erectile dysfunction.
I love it.
Yeah.
Anyway, this study is, and I'll send it to you because I've still got it from Dennis. And it was a report of the study. It was overall, it was an opinion.
Sure.
But there were like 500,000 men in this study. And this, obviously, it wasn't prospective, double-blinded or anything, but it was, the numbers were there.
Right.
Sure. So I wondered about that.
Yeah, I think
also.
I'm just curious on your end as a gynecologist. I would think that should women be on it? Why not?
Why
right?
not?
Yeah.
Well,
Why not?
how does that work?
You're still talking about blood flow and
It's all the same. It's blood flow.
and actually clitoris blood flow.
Yeah.
So there's it's analogous. So
I think from our conversation an hour or so ago about libido.
Yeah.
And wondering whether that can have some significance in that. That might be a third thing, because I was talking about testosterone and oxytocin.
But do women take it?
Well,
not right now.
No.
So it's only a male product. Is that?
Listen,
no, I mean,
it's
I can prescribe it if you want it. I can prescribe
Well,
it.
what's the? I'm just saying it's for ED.
Yeah.
For men.
Yeah.
That's what it's for. It wasn't for something else, and they're using it for ED.
the whole field started with Viagra, which was initially tested as a drug for pulmonary hypertension.
Okay.
And it wasn't working that well for pulmonary hypertension. But during the trial, they were having trouble getting the samples back from the patients, the male patients. And they were trying to figure out why. As it turned out, it was giving them all erections. That's how they figured it out.
Oh.
Yeah.
Okay.
So the whole field of the erectile dysfunction drugs ultimately was behind this whole Viagra trip up. And so it's blood flow. At the end of the day, it's blood flow.
Makes sense.
Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcast, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.